everyone. I am Dr. Johnny Parbani. I am the Chief Medical Officer and founder of Revive. I'd like to start off by thanking Jeff Cohen, David Light, and everyone at AIVA for putting this event together and making this possible. Being here, albeit virtually from Arizona, and addressing everyone in this forum has a significant and sentimental value for me, having been part of the elective IV therapy journey since inception. Our business pioneered, commercialized, and democratized delivery of IV therapy. And it's been incredible to witness the people that we've helped and to see the industry transform and grow into what it is today. I founded Revive over 12 years ago, which has since grown to become the largest global provider of IV therapy. Along with my colleagues, I have overseen medical governance for over 150 clinics spanning 47 countries, and we've delivered over 2 million treatments within our network during this period. And the key takeaways I'd like to impress upon you today is that our treatments have helped and impacted countless of lives, that elective IV therapy can be administered safely, and that the business model can be adapted to fit various regulatory frameworks. Elective intravenous hydration and injectable nutrition therapy. Now, that is a mouthful, and which is why it's often referred to just as IV therapy, has been around for over a half century. Its use in functional medicine probably parallels that time frame. However, it never really gained mainstream popularity. And there have been three societal trends that have permeated even the medical industry, which has propelled the growth of this segment. Personalization, democratization, and the on-demand nature of medicine has contributed to the growth of this industry. Having recognized these developing trends early on, I set out to develop a democratized elective IV therapy business, and I'd like to provide you with some historical context because our business has been copied thousands of times around the world. According to the Center of Medicare and Medicaid Services, the US spent $4.5 trillion on healthcare in 2022. That exceeds the GDP of every single country around the world except for China. However, many of our outcomes, such as life expectancy, maternal mortality, infant mortality, would suggest that we have a poor return on investment. I practiced as a board-certified emergency physician for 10 years, and this was never more evident in my field, which allocates significant resources to what I call the reactive approach to medicine. Now, being in the ER, where a significant portion of patients received IV therapy, I witnessed day in and day out the benefits of these treatments and simultaneously recognized that a subset of these patients did not need diagnostics, monitoring, and can be safely managed in a non-acute, non-clinical type setting. Now, from a personal perspective, I grew up in a multicultural family where I was exposed to the Eastern doctrine of healing and balance for health optimization. When I was working in the hospital, I quickly understood that IV hydration and nutrient therapy had the potential to deliver a new brand of medicine and health optimization through the application of Western medicine and technologies combined with that Eastern philosophy of balance. And as such, I went on to develop a business built on the same safety algorithms utilized in hospitals, focusing on demystifying the clinical experience. Because face it, nobody likes being in a hospital or a doctor's office. I prioritized patient engagement through democratization to create sustainability and ensured that we had the proper governance to track and monitor quality of care. Last but not least, I wanted to promote awareness through education, and it certainly wasn't easy. It took roughly about 6 years for our message to really start to connect and resonate. One can say our business had phenomenal success, and as evidenced by the growth of this industry. However, at the same time, we recognize that many similar practices were not built with the foundation and original intent and could lead to potential risk. And so that's why Dr. Seitz and I will be, and that's what Dr. Seitz and I will be speaking to you about today. The consensus AIVA Clinical and Science Committee position statement on best recommended practice for IV therapy businesses, which hopefully will one day lead to the basis of a standard of care. Now, we're doing this tandem virtual slash live presentation. I hope this works. So I'm going to ping this back to Dr. Seitz for his introduction.
Awesome. Thank you, Dr. Parvani. So so my name is Dr. Chris Seitz. I also am board certified emergency physician, licensed in all 50 states at this time, but currently serve as the CEO and Chief Medical Officer for Guardian Medical Direction. Guardian's mission is really to empower physicians to provide a gold standard in remote medical oversight. Our platform, Guardian MD, now helps support about 600 clinics across the country and about 3,000 clinicians who provide multiple facets of healthcare, but one key thing being in the IV hydration space. So we're honored to be, a part of the American IV Association. I'm humbled and honored to be a part of the scientific committee and work with Dr. Parvani to kind of present to you guys today the scientific committee's framework for best practices when it comes to IV therapy. Like Dr. Parvani, I have a unique experience as a clinician, and I really want to speak to you guys as a clinician today. I'm imagining that many of you who listening in are also clinicians yourselves. I practice travel medicine. I said I licensed in all 50 states, so I practiced travel medicine for multiple years, including during the COVID-19 pandemic. And actually, when I was preparing notes for this, I'm probably going to do it, but I tried to stop. I keep saying things like honored and privileged. I really feel so honored and privileged to not only be a clinician myself, but to also be able to be a leader in this industry and to present to you guys today. So if you hear me keep saying that, I'm just very grateful, and I apologize for the redundancy. But no, as I practice travel medicine, I got the privilege of working in multiple emergency departments across the country, many different practice environments, and obviously I learned a ton through that. And sometimes a lot of times, I was the only physician. And when I say only physician, I don't mean only ER physician, I mean the only physician in the entire hospital. There was numerous occasions where I would be running a code in the emergency department and get called to go deliver a baby because OB wasn't in house. There were times where I'd be, upstairs seeing patients who were in the intensive care unit and then have to run down to the floor to run a trauma. And I learned a couple things. One, I learned to obviously work a lot more than I'd like, but no, I mean, like even 24-hour shifts and the privilege of putting my own health, I think sometimes on the line to be able to help others. But two key things really stood out to me. And if you are a clinician listening in, and the ones who are here will know this, is that what was very apparent is that we practice sick care in the United States today. People have to wait until they really need help to come get that help. And as an emergency physician, I know Dr. Parvani would agree with this, is that we had the privilege again of being kind of that first line of defense against sickness. But as that first line of defense, we also became your access to care. Emergency departments today and emergency physicians like myself have become the first point of contact for hundreds of millions of Americans across the country. We practice sick care because we haven't really figured out the wellness side yet, and I think it could be done differently, and I'm hoping we can talk a little bit about that today. But there have been numerous occasions where people waited way too long to come see me first. And I always say that if the first person you're seeing is the emergency doctor, we're probably already behind the 8 ball. But again, as hundreds of millions of Americans go without access today, we have to find a different way. The physician shortage in the United States is not getting any better. The Association of American Medical Colleges says that there will be a shortage of about 86,000 physicians by 2036. We can't continue the way that we're going. We have to find a way to use hundreds, if not thousands or tens of thousands of other clinicians to bring access to care to the patient. And obviously that's Guardian's mission as we try to empower physicians to provide remote oversight to other healthcare practitioners so that they can open up healthcare businesses and meet patients where they're at. I know it's the American AIVA Association's mission to be able to say, how do we increase access to care? But we have to do it in the right way. It has to be with the right medical oversight, the right protocols and procedures, the right scope of practice being followed, which we've touched on a little bit. And I know Dr. Parvani and I will present more to you today on kind of what is, in our opinion, as a scientific committee, best standard of practice for this. Not because we want to start up a bunch of successful businesses, not because we think that we should decide how medicine should be practiced. We would like a seat at that table though, but because we need to increase access to patients, right? We do not have the right access today. We have to stop practicing sick medicine. So with that, I'm going to turn it back over to Dr. Parvani, and he's going to talk a little bit about kind of the needs, safety, and claims in this IV hydration space.
Thank you, Chris. When people talk about elective IV therapy, the most often initial reaction I get is, oh, it's that treatment you get when you drink too much. Well, regardless of your opinion of IV therapy as a hangover treatment, that impression highlights some of the misconceptions and controversy of the industry, which generally centers around the three topics that Chris just mentioned: the need, safety, and claims of elective IV therapy. Now, the term elective can be a bit of a misnomer, for while IV therapy can be elective, for the countless of lives that have been transformed by IV nutrient therapy, some of which Dr. Barnish presented to you earlier, where conventional medications and treatments have failed, they would argue that it's not elective. As previously presented, there is a growing body of evidence suggesting the potential of IV therapy as an adjunct to health maintenance. The criticism is that much of the evidence is qualitative and not quantitative, which may not meet the rigors of evidence-based medicine. That general opinion also mirrors the critiques of Eastern medicine. For long-term health outcomes, balance and optimization can be harder to define and measure. We live in an era with increasing nutritional imbalances. Malnutrition is becoming more pervasive with modern life and attributed to various causes, including convenience eating, nutrient food chain depletion, food processing, and others. And to complicate matters further, and to re-emphasize a point previously made, we are also exposed to more novel chemicals and pollutants than ever. There was an article recently published by Yale Medicine, I believe last month, that highlights the increasing prevalence of malignancy in young adults. Cancer used to be considered a disease of old age. While the causes are unclear and multifactorial, one plausible explanation is the disruption of equilibrium caused by increased chemical stress, oxidative stress, and malnutrition. Now, IV therapy has two components to it: hydration component and a nutrient replacement component. For anyone that's practiced emergency medicine, such as Dr. Seitz, you'll know that hydration is one of the primary supportive treatments in toxicologic exposures. It doesn't matter what you're exposed to, right? You call poison control, first thing they say, supportive care, IV therapy. The reason for this is that fluids can help dilute toxins and helps the body excrete chemicals, thereby potentially reducing negative impacts. While imbalances in nutrition can technically be achieved by a balanced living, I don't think I know many people that really fit that criteria. As such, IV therapy represents a good candidate for an adjunctive health maintenance. I want to address safety concerns about elective IV therapy. In our practice, we closely monitor medical incidents and have data to support that when delivered with the appropriate governance, there is a less than 0.2% chance of treatment-related incidents. To put that into perspective, Botox, which is the other most common elective therapy, is associated with about 16% adverse incident rate. Now, we're able to achieve this because we utilize a hospital-based algorithm for eligibility, knowing when to turn patients away and recognizing the limitations of our practice. Taking into account what I previously said about elective therapy, the elective nature mandates that standards should match or exceed that of non-elective treatments. To do that, a valid informed consent must be obtained on each and every encounter, so patients always know the risk, benefits, and alternatives to treatment. Medical screening is paramount because when employed appropriately, it can serve as a powerful tool to risk stratify patients for eligibility of IV therapy. And I would strongly caution against relying on a questionnaire as the sole determinant for eligibility and advocate for judicious use of medical screening exams to ensure there is no misunderstanding or misinterpretation of health history and information provided. Pharmaceutical handling is paramount in IV therapy, as you just heard. Non-pharmacy clinicians may not be as experienced in the complexities of mixing nutrients or chemicals and may not realize the importance of evidence or testing. The United States Pharmacopoeia recognizes that pharmaceutical handling is routinely performed by various credentialed professionals and provides robust guidelines designed to minimize risks for patient safety. Clinical claims for IV therapy is another controversial topic. This was particularly highlighted during the COVID pandemic when some practitioners were making unevidenced claims and got into trouble with the FTC. The controversy lies in the fact that there is a lot of anecdotal evidence and clinical experience to suggest benefit, albeit as previously mentioned, quantitative data that meets the rigor of evidence-based medicine is often hard to come by. There is a lot of misinformation in this space. However, it is accepted that nutrition is required for healthy living and health maintenance. I think what is debated is the how, why, when, and what of nutrient supplementation. As such, education is a key focus for all stakeholders. Medical professionals need to understand the complexity of IV therapy, to apply best practice, and to recognize regulatory considerations to maintain compliance. Regulators need to understand the foundation, the data, and the intents of this practice segment to provide uniform expectation to safeguard patient health. And finally, education for the end users so that they're able to recognize unsafe or sometimes predatory practices and inappropriate claims to avoid pitfalls. Once all of these conditions are met, the safety, need, and claims are satisfied, then and only then can we start to approach innovation. As you heard earlier, there's significant potential for research in this space, particularly due to developments in genomics and biotechnology that can lead to new discoveries and applications to further improve population health. However, in order to do so, set standards and foundations must be in place. I'll turn this back over to you, Chris.
No, thank you. So I think this is a very unique opportunity that we have. Is that I said before, you know, we've learned how to practice sick care in the United States today. And I think we're starting to see, as Johnny's talking about here, this transition and this opportunity for us to start to practice health optimization and wellness. But what do we mean by that? And I think it's an interesting opportunity for us as clinicians because we've never been asked that before. We've always been told here, when something goes wrong, here's what you do. And now the opportunity is to say, well, how do we prevent things from going wrong? And it's an immense responsibility as well, right? We need to understand how invasive of procedures can we pursue in this endeavor for health optimization and wellness, right? How, you know, what are the true risks and benefits? You know, no longer is it, hey, I understand the risks and benefits, but your health is on the line and I have to do what's right for you in this moment. It's to, hey, what types of strategies and things can I do in advance of you getting sick that protects your health and also prevents illness? And I don't know if we have the answers. I think that's the opportunity that we have here today. I think it's the opportunity that we have as clinicians to come alongside other clinicians in other areas for the nursing boards and the medical boards and the pharmacy boards and other regulators, as well as us as clinicians and the patients themselves to come together. But as Dr. Parvani said, it all starts with education. Earlier, you know, Felicia and Jeff were talking about scope of practice. And that is kind of the first thing. And I know AIVA will probably send out this position statement that we've created to everybody. I'm not just going to read through it, but we're covering the topics of it today. But one key component and one key pillar is understanding education, and as a part of that, scope of practice. What is in my scope of practice as a clinician to do or not do, whether with supervision from a physician or not with supervision from a physician? And again, that's a little gray. I think this is an opportunity that if, the regulators and the boards that may be tuning in, I'll ask you, like, help us define that better. I think we need some assistance there. We're happy, we want to sit at that table. I want to tell you what I can and cannot do based on my training. And one of the things I can't do is put in IVs. And so here's the thing. And this is what's so interesting is that I have a pretty big scope of practice as an emergency physician. But I also have a responsibility to understand what I'm truly trained to do and what I'm good at doing within that scope of practice. So we need help defining scope of practice a little bit better. And I think we all need to come together to do that. And then we need to have some honest conversations about ourselves. I am a medical director for multiple nurses and clinics, and I do a really good job of overseeing the practice of medicine that's under my supervision within their clinics. But don't ask me to put the IV in. That is a terrible idea. I was in an emergency department one time and the patient said, listen, I don't want the nurse to put in my IV. I want you to do it. And I was like, I mean, okay, but we're in for a wild ride, lady. I mean, it was like, there's no way. So again, like, scope of practice isn't enough, right? We have to understand there's additional training that has to take place and additional education that has to take place. And that's our responsibility as clinicians, to be able to show that we have that training. And doing the training once also isn't enough. So defining scope of practice is one thing. We also have to understand what training do we have within that scope of practice, and are we participating in the continuing and elevation of training beyond there? There's a difference between continuing education and repeat education. And I like to make that distinction, is that repeat education is me rereading the same continuing education article I did before, taking the test and saying, hey, I'm still good to do this, versus based on data and outcomes saying, hey, I think I can do this better. And how do I do this better? And what does that training look like? And how do I elevate my education there? Another huge piece that I think we as a healthcare society are missing in general is patient education. Again, I have an immense responsibility as a physician. If I tell you as a patient, hey, I think this is what's right for you, there's a high chance you're going to go forward with that. And that's a big thing for me to steward well, because I better know that I'm giving you the best advice, that I know what I'm talking about, that it is the best thing for you. And that's hard. Those are not always cut, yes or no, right or wrong answers either. So patient education is key. And I think this is another opportunity for us as clinicians and a healthcare community to start to really build awareness, like we're doing today, and education around this industry, but also around some of the therapies that we do administer. What do we know about it? What don't we know about it? I really respected, and this may be a little controversial, but I really respected the physicians during the COVID-19 pandemic when asked about vaccinations, when asked about treatments, who said, I don't know. I just don't know. Because you're always going to find, we talked about the bad apples, that you're always going to find some research to prove one point or another point. We really need to start to come together to build enough data to say, hey, this is safe, this is not safe, this will work, this will not work. But that takes time, and that takes a community of healthcare professionals and regulators and boards to come together to do that. So again, as you review these position statement, which I hope you do, I will encourage you to look at this component that we've built in there. There are multiple recommendations we have around scope of practice. Only a licensed provider who has a scope of practice to deliver this care should be delivering this care. Now, what do we do with that? Well, we need to understand that scope of practice better. We need to define it better, and we need to take responsibility for that training and education. But there's also a patient education component that we need to take into consideration. And then there's the continuing education component as well. There's two other main pillars and themes you'll see within our position statement, which I will go over next. But first, I'm going to turn it back to Dr. Parvani and talking a little bit about the challenges. I mean, and I based a little bit of them here, but like some of the challenges that the regulators face, as well as those who are trying to interpret regulations face currently, specifically, obviously, in the IV hydration industry. So, Dr. Parvani.
Thanks, Chris. As I stated in my introduction, the trends and factors that have propelled the growth in this industry have also led to this multitude of an explosion of different business models that present challenges in oversight with regulatory inconsistencies. This creates problems for businesses and consumers and can cause confusion and risk. Now, being in a relatively new industry with novel applications, it is to be expected for regulations to lag behind practice. I'd like to share another anecdote from the infancy of our practice to highlight some challenges that others, I know at least Felicia, has undoubtedly experienced as well. There was no precedent to our practice model when we first commenced operations back in 2012. There were elements of similarities across different traditional healthcare offerings, but nothing that matched perfectly. As such, being compliant clinicians, we decided, okay, we're going to perform our due diligence journey by starting and reaching out to the local health departments. So we contacted the health departments and they said, sorry guys, we're not able to provide you with any feedback because there's no other similar business that's in existence. However, use your best professional judgment and contact your professional boards. So we said, okay. So the next stop, we reached out to our medical boards. And after speaking to them, they said, hey, you know what? You actually are handling a lot of pharmacies and managing pharmaceuticals. So we recommend that you actually reach out to the pharmacy board. Okay. So we called the pharmacy board. And after speaking to them, they said, well, you know, since you don't dispense and since you don't actually have pharmacists on staff, we don't actually regulate your business. Go contact the nursing board. And so finally, we're running out of boards here. We contact the nursing board and they were very helpful. And they said, hey, you know what? We've got this general scope of practice. But when we asked, hey, can you help us clarify something? Oh, no, sorry, we can't provide you with that. Go back to legal. And so after this entire round robin, we went back to legal and ultimately ended up back in almost square one, utilizing our best judgment. Now, I'd like to think that those days are gone, but clearly they're not. But the fact is, there's still a lot of ill-defined regulations. However, the good thing is that the industry now has the attention of regulators. And this next chapter of governance will depend on leaders to build bridges, as Jeff mentioned earlier, and work collaboratively to help prioritize patient safety. Our organization is headquartered in the United Kingdom, even though we started our business in the United States. And when we first entered the UK market, there was an equal amount of unfamiliarity with ill-defined regulations. We were able to successfully build a relationship and helped lobby for stricter governance. And today, there is a uniform standardized regulations across the entire United Kingdom. And it is a criminal offense to operate an IV therapy without it being inspected and authorized by a Central Care Quality Commission. Now, I would say we are at a slight disadvantage here, for even though we operate in the United States, the reality is we have 50 different states, all with their own regulations, some of which will directly contradict with each other. It is important to understand the differences between clinical guidelines and regulations. Clinical guidelines are based on scientific principles, and I would say for the most part, applies equally regardless of geography. Clinical regulations often do factor in these scientific principles, but have additional social, political influences, including jurisdictional and enforcement considerations. I have witnessed instances of over-regulations that are inconsistent to clinical or common practice or even common sense, and also the inverse of under-regulations, where more stringent governance would be of benefit. As mentioned, this type of inconsistency can lead to a cat and mouse type situation with practices trying to exploit loopholes, disregarding impracticalities, all of which just furthers risk to safety and care access. So to all the regulators that are listening in or that are in attendance today, I'd like to sincerely invite you to better understand our industry and welcome your feedback on our proposal for best practice. To all practitioners, the regulators have a job to do to safeguard human health, which perfectly actually aligns to your Hippocratic Oath. We can all work together to further the potential of nutritional medicine IV therapy and the opportunities of making a positive impact. Now I'm going to turn this back over to Dr. Seitz, who will provide you with a brief overview of the 10 consensus points, which we feel are the critical elements for any practice looking to offer IV therapy or that are offering IV therapy presently.
Thank you. So again, I'm not gonna go through this list of 10 things. Like I said, this will be sent out, but I do want to encourage everyone that we as a scientific board, when we put together this consensus statement and position statement on the industry, very much did so with the hope that you would reach out and read it and tell us how to make it better. This is not us telling you how we want to do things. This is us telling you how we feel this industry should move forward, but we want that input. We want that feedback from everyone, whether you're a clinician or a regulator or a layperson who's, received IV therapy. We want to know we want to hear from you. We want to know how to do this better, okay? But again, instead of listing off the 10 things, I'm going to give you the 3 pillars. The one I already gave is this, and that was the scope of practice and adequate training, all right? High level that only a licensed provider with a scope of practice that includes IV therapy administration should be practicing that type of medicine. The right medical oversight needs to be in place for that scope of practice. Patient education needs to play a key role, and continuing education is vitally important as well. The other 2 pillars I want to highlight today really kind of fall into 2 categories: safe treatment and appropriate monitoring. Safe treatment means that we really need to build a standard of care around how this is delivered. Okay, there are certain things that we do know. We do know that aseptic technique for the administration of, putting in an IV should be followed by everyone, right? So there are things like this that we absolutely know, and that is going to be defined by protocols and procedures. So we need to be working as clinicians to put together, and your medical directors and supervising physicians should be a part of this, obviously, in guiding this. There needs to be a very clear protocol and procedure on how we are going to administer these services and these therapies. But just having a protocol and procedure, again, is not enough, right? We need to make sure that our clinicians understand and follow these protocols and procedures. So quality assurance, QA and QI, is also of vital importance. And a lot of this always continues to tie back to the education. We need to make sure that we're not only educating on the therapies themselves, but on how to administer these therapies in a standard of care. Another important piece of this is that a patient-provider relationship must be established. This is the practice of medicine. We all agree on that, at least on the scientific board and with AIVA today. This is the practice of medicine, so it has to be treated as such. Licensed providers, as defined by the boards, and there's about 11 states that have come out with position statements specifically on IV therapy and IV hydration in this past year, have stated that licensed providers are defined as physicians, nurse practitioners, and physician assistants. They are the only ones who can diagnose and treat patients. So a patient-provider relationship must be established by one of these licensed professionals before therapy can be administered by another clinician in the healthcare community. That is very important. Again, treatment protocols and administration protocols need to be in place. So that's one key piece. The other key piece here is ongoing monitoring. And I think this is where we have a lot of room to improve. And this is something that I think Revive has done immensely well, and why we have the data we have today, but a lot of us maybe have not thought about. We've talked about how, one of the things that we want to be careful about is patients coming in and ordering off of a menu and walking out. And we want to build healthy individuals and give them treatments that can help them sustain a healthy lifestyle, optimize their health, and improve their wellness. We can't do that if we don't know if what we did helped. So we need to have things in place in our clinics and in our programs that follow up with these patients. We need to be monitoring outcomes, and we need to be reporting adverse outcomes. There is nothing that is 100% safe all the time, never an issue, everybody always wins. It's just not how our bodies work. That's not how medicine works. So in order for us to elevate this practice of medicine in the IV therapy space, we have to be monitoring and reporting on good outcomes and bad outcomes. And how we define that is important too. We need a consistency within the industry of what do we mean by bad outcome? Do we mean that the patient didn't improve? Do we mean that the patient had something bad happen to them? Do we mean that they didn't have to go see their doctor, did have to go see their doctor afterwards? These kinds of things. So we need to get better at the ongoing monitoring and follow-up of patients who are receiving these therapies. again, the scientific board's position statement has about 10 items, but they fall into these 3 categories, right? Adequate training, safe treatment, and appropriate monitoring. And if we do these things as a community, we really can drive significant outcomes for our patients, which we've shown in the data, but we need to come together to do that. So anybody out there who is listening, who is participating in IV therapy, who owns a clinic, runs a clinic, is a clinician in a clinic, or anything like that, I would encourage you, please take a look at this position statement and make sure that you kind of line by line ask yourself the question of, am I meeting this type of standard of care? And also, where can I improve on it? Give us a call. Tell us what the 11th one should be in this. We'll make it. We'll keep it short. We won't make it like 8 pages. But again, give us those things so that we can continue to improve this. It's only through that ongoing, collaboration of healthcare that we can really drive things forward in a safe and compliant way, which, as Dr. Pravani stated, is all of our goals. So thank you very much. And Dr. Pravani, I'll turn it back over to you to close us out.
Thank you, Chris. I realize that was a lot of information that we have just delivered in a very short amount of time, and you will need some time to process it. I'd like to just close off by reinforcing kind of the 3 takeaways I introduced when I opened this presentation. That elective IV therapy treatments have helped and impacted countless of lives. That treatments can be delivered safely with the proper governance structure in place, and that the business models can be adapted to fit various regulatory frameworks. The IV therapy industry is rapidly growing, which is the evidence of demand. Now that we have had the experience in the industry and the practice data, we can utilize that information to ensure that the demand is met with supply that utilizes best practice with the appropriate framework for safety and compliance, that is primed for innovation to improve human health and care access, and that can also help decompress an overburdened traditional healthcare system. I want to thank you all for your time and giving me this opportunity to share my experiences and insights with you. I'll leave you with one final pearl, which may sound a bit like a cliche, but it's true. There's no need for anyone out there to reinvent the wheel. Capitalize on our collective experience. Utilize the resources and tools that have been developed and channel your entrepreneurial spirit to further innovation. Thank you.
Great job. Thank you, Dr. Seitz. Thank you, Dr. Parvani. Our last speaker, we're going to flip back to a little bit more of a deeper clinical dive. I'd like to introduce Dr. Steve Rawlis, and also from who's the Drip Bar CMO, and Natalie Teague from Aesthetic Medical Partners. Thank you.
Thank you, David. Thank you, David, for organizing this, and to Jeff and Autumn, Sarah, Ben, Sam. We appreciate what you guys done. I'm thrilled and honored to be part of the scientific advisory board for AIVA, to work with Chris, Brad, Johnny, Felicia. It's a big deal for us, all of us, to be able to sit down and write these position papers that can inform industry. I'm going to switch gears because we've been talking about regulatory stuff a lot. My wife, Michelle, and I run a clinic where we see in excess of 100 IVs per week. For us, vitamin therapy is not elective. This is our medicine. And part of what I'm going to talk about today is I'm going to bring some nuance to this discussion. And I'm privileged too, because we have a great sort of a broad spectrum of intellectual capabilities within our scientific advisory board. I'm proud to be the only naturopathic physician on the board. So for me, functional medicine is what we do. So I'm going to bring insight to what we're trying to talk about, because part of this whole regulatory idea is if we don't understand exactly how IV vitamin therapy works, we really can't regulate it. We really can't make it safe because we don't understand it. And it's not well understood. I'll give you an example. We had a patient recently, colitis, hadn't had a solid bowel movement in 18 months, was reluctant to go on long-term prednisone for obvious reasons. We ran blood work. identified the diagnostic sort of deficiencies, administered one bag, which addressed some of those nutritional deficiencies, including 10 grams of vitamin C. She had a solid bowel movement that night and the next day, and she's been fine since. So the question becomes, how is that even possible? It's difficult because most doctors don't even really understand how vitamin C works. So let me just run this by you, just for the sake of our audience and for those that are watching. So vitamins and minerals are very tightly regulated within our body. It's very complex. Most vitamins do not follow first order kinetics, which is also very interesting. First order kinetics just basically means if I take a drug and double it, it doubles the amount of drug in your blood. Vitamins don't work that way. So your normal millimolar concentration of vitamin C in the serum is about 0.8 millimoles. And millimolar just basically means if I have a liter of lemonade, and in that 1 liter I put 80 granules of sugar, there's 80 millimole of sugar concentration, millimole concentration in that lemonade. So vitamin C, no matter how much you take orally, will never exceed 220 millimolar. Yet the moment you do that injection, the moment we did that injection of 10 grams of vitamin C, her millimolar concentration went to close to 10,000 millimolar. Anything greater than 300 millimolar is clinically different. Vitamin C now has the ability, and in the enterocytes that are lining her gut, they all have vitamin C transporters. So if you don't understand sort of the pharmacokinetics of how these sort of medications work, it becomes impossible to sort of even understand why it's relevant. If we have a neuropathy and when we start a drip with alpha lipoic acid, you can't do that orally. In fact, what's prescribed orally is the D form, which isn't even the normal enantiomer, which is the type of molecule that exists in nature that we're even able to absorb. Yet when we run an IV drip with alpha lipoic acid, you can absorb it. When we do a B12 injection, so B12, I know that Dr. Barnish has sort of posted earlier, the concentration of B12 in the body is going to be somewhere between 250 and 750 picomole per liter. Now, a normal doc like Chris Seitz, when he's looking at this in the ER, he's looking within that regulatory framework. So is Chris Davis, right? And you're saying, okay, it falls within that framework. Yet, if someone has a neuropathy, B12 doesn't bleed through into the neural tissue until it's at greater than 1,300 picomole per liter. That's critical to know. So you have to inject. Otherwise, you can't get to the greater than 1,300 picomole per liter enough to impact the neuropathy. It's impossible. And this goes on and on and on. It's funny, you know, we talk about sort of the history about, and I know that we're under a tight timeline, Dave, so I'll make this tight and interesting for everybody. If you do a survey of Myers cocktail, you will find 1,000 different versions. We talked about this with Ben last night at dinner. 1,000 different versions. Yet people don't even really know what the Myers cocktail was. So in 1984, Dr. John Myers in Baltimore died. His patients were and he had been administering infusions, IVs, to thousands of patients with very poor clinical record keeping. So no one knew what the formula was. Most of his patients went to Alan Gaby. Alan Gaby is a giant in terms of integrative and functional medicine. They started seeking care from Alan Gaby. He began to piece together Dr. Myers' original IV formula, which included magnesium, calcium, B6, B5, B12, and vitamin C. Is that what's in most Myers right now? And interestingly, he did it in a 20 cc syringe, sometimes in a 10 cc syringe. Now it's done in a 500 ml bag, 100 ml bag, 1 liter bag. But I would ask those people that are injecting that, the moment you take an osmolarity from hypertonic to isotonic, does that change the nutrient absorption of that bag or the nutrient absorption of that nutrient? The answer is yes. How does it do it? Do the clinics that are doing these IVs even know that? Do they know how it's changing the absorption? And how, depending on what your patient looks like, is how you change the osmolarity of the bag? We don't. It's random. We sort of touched on that already. There is no standards. Part of what we're committed to doing is not just informing policy, but best practices. This week, in fact, we completed a study on high-dose vitamin C and chemotherapy with Trinity School of Medicine, and looking at specifically safety and looking specifically at efficacy, using vitamin C in concert with chemotherapy. And what we found was, one, not only is it safe, but the evidence is so compelling. And I know Dr. Barnish has done a similar type study looking at quality of life. We weren't looking at quality of life. We were looking at actually enhancing the efficacy of the standard of care. It's a big difference. Nothing within this industry takes away from the greatness of medicine. But we've all talked about there are massive blind spots within the context of medicine, including nutrition. Most family docs get an hour, 2, sometimes less of nutrition. Yet in an era that is defined by chronic lifestyle diseases, unless we address nutrition in the context of primary care, we will never sort of undo this. So I'm going to leave you with that, because honestly, I could talk to sort of about every single protocol for every single disease you could possibly think of, and you could just call it out and I'll tell you exactly what to do. But I do want to leave it to Natalie. And David, is Natalie on? To touch on other things. And if there are questions, for sure. Hey, Nat, I'll leave it to you. And thank you for your time. I kept it short. I'm proud of the work that we're doing. And I'm proud of this organization as well. All you.
Hi, thanks. Hi, I'm Natalie T, board certified family nurse practitioner with a background in critical care and emergency medicine. I am also the clinical director for Aesthetic Medical Partners. We are a nationwide physician oversight group helping registered nurses, nurse practitioners, and PAs find physician oversight. I actually have a private practice as well, and I'm licensed in multiple states in the US where I offer telehealth medicine. And what I really want to share with you today is that there are multiple different methodologies that IV can be used for. And you've got to hear a lot today, which I know kind of probably felt like a fire hose of information. And in my clinic, along with IV therapy, I practice functional medicine, and then I also offer therapeutic wellness. Compounding therapeutic nutrient therapy is available in many forms that don't necessarily always involve vitamins, such as bioidentical hormones. So I just want to share with you complementary things that can be used in conjunction with IV therapy. I'm also a certified BioT practitioner, and I am trained in hormone replacement therapy to treat menopausal symptoms in women and andropause symptoms in males. And I also specialize in hormone optimization. Hormones play such an important role in regulating many processes in the body, including growth, development, tissue function, and cellular regeneration. As we age, our hormone levels naturally decline and can impair the body's ability to repair and renew tissues. So in conjunction with IV nutrient therapy, and with bioidentical hormone replacement therapy, with or without hormone optimization if the patient needs it, these are safe and effective treatments that can offer relief for many common and debilitating symptoms that medical providers often overlook. And some of these symptoms include exhaustion, stress, foggy thinking, weight gain, sleep disturbances, and much more. And I just bet at least one person in the audience today has felt or is feeling one of those symptoms I just mentioned. And so I'm so excited about today and what all got presented, and that so many have joined us today. And I look forward to watching more people get better and feel better, and starting the conversation and for people to ask more questions. So thank you for your time.
Thank you, Natalie. Thank you, Dr. Rollis. So on behalf of the American IV Association, we'd like to thank everybody, especially our key vendors and founding members for coming and joining us in person today, and the thousands of people that actually joined online, which was an amazing turnout for a first of its kind webinar like this. If you've got any questions directly related to the AIVA, please contact me. Very simple email, info@americaniv.com. And all of the speakers that spoke today, their contact information is available on the screen right now. So next couple of months, we've got summer webinar series from AIVA that'll run until September, early September 8th and 9th. That's when our Vibe conference in Boston is. And then after that, we'll do an event like this again in mid-October. So thank you all very much and have a great rest of the day.